Johnston. I am the Assistant Director for PhD programs and interprofessional education here at the College of Nursing and Health Professions. I've been asked to introduce our speakers today, who are presenting the second in our series of IPE competencies. Each of these workshops are geared towards one of the four domains of IPE, interprofessional education competencies, and the second one, this one is on value in the domain of values and ethics. Other domains, of course, are roles and responsibilities, interprofessional communication, and teams and teamwork. Leading our presentation today is Kimberlee Montgomery, who is the Chair of Advanced Nursing Department at Drexel University's College of Nursing and Health Professions. She is the founder of Drexel University's Partnership for Interprofessional Education, IPE. Dr. Montgomery created an innovative, award-winning IPE curriculum utilizing novel learning modalities, multi-fidelity simulation, and structured debriefing that has been adopted by leading colleges, universities, and medical centers nationwide. And her work has been widely disseminated through peer-reviewed journal publications, national conferences, international presentations in Russia, Korea, Canada, and Brazil. She is a consultant for the National Center for Interprofessional Practice and twice funded by the Macy Foundation to design a case-based simulation curriculum for collaborative practice and professionalism. And we are thrilled to have her here, both presenting to you and all the people who are joining us online. She's also being joined by Dr. Owen Montgomery and Dr. Mary Gallagher-Gordon, who I'll allow them to introduce themselves when it's their time at the podium. Thank you. Take it away.
So, good morning or good afternoon, and thank you for having me today. I did bring, as Darren said, two members of my team. We have a wonderful team that works on interprofessional education, I guess, since 2008, doing various different things. Part of my major team is Dr. Owen Montgomery. He is the chair of OBGYN at Drexel University. And I also have next to me, which you'll probably be able to see her leaning against the podium, is Dr. Mary Gallagher-Gordon, who is the Associate Dean of Technology and Compliance. Yes, and we've been working on lots of things together. So I really believe that when you do an interprofessional talk, it's great to bring more than one discipline because you get lots of different perspectives from the room and as well as online. I'd love to know, other than nursing, and we know we have PA and we have medicine, do we have any other disciplines in the room today?
I'm from the physical therapy and application science.
Perfect, physical therapy and application science. Anybody else on the chat box, Linda?
Counseling.
Counseling? Yes. Okay, so that's 5, that's perfect. Okay, so let's get started. I think I can do it this way. Let's get. Okay, so the learning objectives today, pretty easy, are to explore the motivating factors that necessitate interprofessional practice, discuss the roles, responsibilities, and ethical considerations of an interprofessional team and team members, demonstrate the importance and necessity of team collaboration, and discuss the not-so-secret secrets of implementing an IPEC core competency, values, ethics into an interprofessional curriculum. So I was asked basically today to talk about the ethics competency, not so much about what is ethics, because I believe we've been teaching ethics for many, many years, but how do you teach the ethics competency, core competency from the IPEC competencies into your curriculum without just basically standing up and lecturing? How do you make it interesting, interactive? The modality that I'm going to explain to you today is from a Josiah Macy grant that was funded through DUCOM and College of Nursing and Health Professions about 1.5 years ago to develop modules to help teach professionalism in an interprofessional way. That being said, it's really not just about the interprofessional competencies, it's really marrying the interprofessional competencies and professionalism together, because if you look at them all, they really do deal with interacting with patients and us together as a team. Next slide, thank you. So the definition, you know, it's great to start with definitions so that everybody's on the same page. The WHO did a very public definition in 2010 of what is interprofessional practice. And most of us who are practicing, whether you see patients or clients, you know, we practice in a interprofessional way, one way or another, but what really does that mean? So the definition that's really well-versed and known everywhere is multiple health workers from different professional backgrounds providing comprehensive health services, working with patients, their families, caregivers, and communities to deliver the highest quality of care across settings. On this slide, we definitely know about the patients. A lot of times what we do forget is the family, the caregivers, and the community, because we really work in a sick environment, and a lot of times worrying about getting the person in and out of the hospital or in and out of the office. And we have a big push to do health care prevention and health promotion, but we really talk about the patient. Next slide. So in 2016, when IPEC redid their competencies a couple of years later from previous in 2011, they did a change of what interprofessional practice is, and they redesigned the competencies to put the word collaborative in. So what is interprofessional collaborative practice? It kind of sounds redundant. It sounds like, you know, interprofessional practice should be collaborative, but unfortunately that definition did not translate. So another way to look at this is a process which includes joint communication and decision-making, which enables the synergistic application of the entire group knowledge and skills. What's really important when we're going to be talking about ethics and how to teach ethics is the elements of collaborative practice are, if you look at what's in the yellow, responsibility, accountability, coordination, communication, cooperation, assertiveness, autonomy, mutual trust, and respect. When I look at definition of ethics, that's kind of what it says, right? I mean, that's what we teach. It's just how do you teach it? So really, interprofessional and interprofessional collaborative practice married with ethics and professionalism is the perfect match. Next slide. So I'm going to bring Dr. Montgomery up, who's a wonderful historian and loves to talk about the history of interprofessional education and why we are doing this today and why we seem to be so stuck in institutions across the globe of trying to get the word out that this is what we should be doing. Why is it so difficult?
So good afternoon. Thank you, Dr. Kimberley. She likes to say I do history only, I think, because she thinks I'm just old. But, you know, I think that, you know, the famous quote that, you know, if you don't learn history, you're doomed to repeat your failures. And so if we don't know where we've come from, it's hard for us to project where we should go. So on the slide, you see an abbreviated version of a longer presentation that we've given previously, but it talks about over 100 years of siloed, this says medical education, because in fact, it has to do with medical education, but you know, for all of us here, it's about health profession education, because there are 5 different professions, either here in person or on, you know, on the web. We have 45 years or more of reports from the Institute of Medicine about how we should think about working together. And we listen to them, but we haven't necessarily achieved all we could achieve. There are definitely other groups that have reported, Lancet Commission, the World Health Organization, IPEC, which you've heard about, which I think is really all of us. It's 15 different medical specialties, nursing specialties, osteopathic, allopathic, physical therapy, pharmacy, I think veterinary is in there. So all of our leaders have said, really, we need to think about this differently. And of course, Robert Wood Johnson, the Macy Foundation, which has sponsored some of this work in terms of chipping away. So let me just paint a little bit of the history. So early American healthcare was really about medical care, because I believe the first academic college of nursing was 1908, the University of Minnesota. I learned that at another meeting recently. So in 1910, the Carnegie Foundation funded what's called the Flexner Report, the famous report which not only looked at how healthcare, how medical care was being taught in the United States, which was really an apprenticeship model, and said, and essentially condemned medical school education at that time, and said we need to have a structured way. And it really ended up with the classic medical school, which is 2 years of basic science and 2 years of clinical education. And it really talked about, medicine and mutual trust and respect and collaboration were not in the Flexner report. So I think that changed healthcare in the United States and allowed us to really have a renaissance. I'm an obstetrician gynecologist. I will tell you that one of the unheralded miracles of healthcare in the 20th century was the 99% reduction in maternal mortality in the United States and the 99% reduction in neonatal mortality in the United States with the changes in scientific method and how we taught and things like that. So it was really important. But we don't do anything else the same way we did in 1910. And so 100 years later, the Carnegie Foundation again commissioned a report to look at medical education. And what they said is that this was really a wonderful idea and it's really gotten us where we are. But the world has changed. Science has changed. Informatics has changed. There are more patients to take care of. We need to think about this as teams of providers. And so we need to change this siloed education. And we need to boldly go into the future and reinvent healthcare education. And we need to do it all together, which is really essentially previewing the IPEC report, where all the organizations said, absolutely this we need to do. And in fact, at the plenary session at the American Association of Medical Colleges, which is the big meeting for medical schools, the outgoing president said, I think finally we're getting somewhere with interprofessional education. He was one of the authors of the IPEC report. So why is this important? I mean, we're doing fine, right? There's nothing wrong with healthcare. Everybody's healthy, right? You go to the hospital, there's no problem. I think, so we chuckle. So one of the things we did just a week or two ago when we were doing an interprofessional education session with midwives, OBGYN residents, nurse anesthesia, undergraduate nursing, PAs, I think that was it, and law students. So Kim asked the question, who here has ever had a loved one in the hospital and went and sat by their side? And everybody raises their hands. And why did you do that? And the answer was, well, we wanted to make sure they got the best care. We wanted to make sure that nothing bad happened to them. These are healthcare educators talking to healthcare learners, and we're going, well, if our son goes to the hospital, I'm going to sit by his bedside because, somebody may try to give him insulin, like to our son, or order the wrong test, like on my father, or something like that. So we know that mistakes happen. Well, so does the Institute of Medicine, right? So the Institute of Medicine report, The Error is Human, came out and suggested that 98,000 deaths a year were from errors that happened in the health system. We went, oh, no, that's not true. That couldn't, well, maybe it is true, right? And why does it happen? Well, it doesn't happen because I got up that morning and said, I'm going to practice bad medicine today. I'm going to just take horrible care of my patient. We all got up in the morning. We're all well educated. We mean well. We want the best for our patient. So if something happens, something went wrong with the teamwork. And it's usually about communication. And it's usually because we don't know how to talk to each other. And it's partly because we never talk to each other until we're thrust into the actual environment of being in a clinical situation. So if we don't educate our students together, they don't learn how to talk to each other respectfully. They don't know what each other does, role clarity, all these kind of things. In fact, I'm stealing a little bit of Kim's thunder from the meeting, but one of the things that we asked the students in our interprofessional sessions, it turns out that the big quandary is the midwives don't know what PAs do. PAs don't know what midwives can do. And everybody's kind of figuring out what midwives do compared to OBs. I mean, this is all women's health, but we don't know what each other does. And if we don't know what each other does, then we can't have confidence and trust in their abilities. And we need to be assertive and say, well, I can do this, I'm trained as, right? So I think that comes up. Well, okay, so the Error of Human report's almost 20 years ago, so we're much better now. We fixed all the problems, right? So last year in the British Medical Journal, the authors reported that now they believe that there's 254,000 deaths related to medical errors in the United States, the third leading cause of death in the United States after heart disease and cancer. So we've focused a bright light, but we haven't We haven't changed the needle yet. We haven't really gotten where we need to get, and we're still chipping away at this idea that we need to learn together. We need to learn together as colleagues. We need to redefine medical education with everyone at the table. And partly, there was this old phrase that only Nixon could go to China, right? You could only have a really conservative, the sort of anti-communist one could actually then go to China and change the world. You have to make sure that the medical profession comes to the table and says, yeah, we get it. Everyone needs to be at the table. I need to have respect. I need to trust my colleagues. So I think women's health is such an obvious example, a microcosm, because we know we work as a team. And in labor delivery, we're taking care of patients. We're a team. I know I'm not in there all the time. I know I have a role to play, but I need my colleagues by my side. I need anesthesia, right? I need the labor and delivery nurse. Thank goodness I have great midwives that work with us all the time, because I might be doing an operative delivery and my midwife is watching and taking care of the other deliveries. So we know that we need teams. So I think it's not a surprise that sometimes in women's health.
And it's also patient-centered, family-centered care.
Patient and family-centered, exactly right. So I think that it's not surprising that women's health, both in College of Nursing health professions and also in College of Medicine, is sort of leading the way. The Institute of Medicine made some other reports, very important, that if you have a gap between where we want to be and where we are, there's a chasm. We need to build bridges across it, and that bridges have to be education. And I think, and we'll talk about the actual words, but I think the important words come up is that everyone agrees that we should be teaching as interdisciplinary teams. We should be using tried and true methods such as simulation. We should be maximizing informatics in how we communicate. And we need to make sure that we're emphasizing quality, patient-centered care, and the not so secret, which is that we have to build the trust and the respect into healthcare education from the first day that our students take their seat in the classroom. The Institute of Medicine also in 2010 address the future of nursing, and I think this is important for the medical people to see the Institute of Medicine. What they said is that nurses should practice to the full extent of their scope of practice. I mean, honestly, there's not enough of us to take care of all of the needs of all of the citizens of the United States or the citizens of the world, and so everyone needs to be doing the best they can and to divide it up. Nurses need to get additional education, but most importantly, they need to be full partners with physicians and other healthcare professionals in redesigning healthcare education in the United States. And that's what we're doing here, is redesigning healthcare education. You saw a nice slide from the World Health Organization. I think we have another slide. Oh, IPEC first. So, okay, so IPEC, which we talked about, and then WHO. Oh, there's IPEC. We got 15 institutional members. These are the 4 domains you've already heard us talk about. We're doing value and ethics, but there's roles and responsibilities, communication, teamwork, achieving the triple aim. There's not enough money, so we need to get better healthcare outcomes for more people, and we need to provide value. We need to do it at a reduced cost. And one of the ways to do it is that we all work as a team. Everybody does what they do best, and then sometimes you take the more expensive professionals and you have them do what they do best, and actually that adds value to the system. So, can I keep going?
Yep.
Oh, that's you. Never mind. I can't do that. Well, I mentioned the Lancet Commission also addressed it. I think that when we talk about population health, the WHO really is where we go. And they talk about, you have the population that is not meeting their health needs. And you have learners who are learning separately. And if you put the learners together and they learn how to be, they're trained interprofessionals, then you move the entire equation from health needs to interprofessional education, which drives interprofessional practice, which you heard Dr. Kim talk about. Interprofessional practice improves the outcome of the individual patients, and then ultimately we achieve the improved population. So I think the WHO has it right. I think IPEC is on board. I think we're here today to talk about how we can get where we need to get, because there's still 254,000 deaths that we can avoid.
So I'm gonna have you work.
Okay.
So this slide, as you heard Dr. Montgomery talk about, myself, Dr. Montgomery, Mary Gallagher-Gordon, we do consult a lot of consulting work across the United States and now a little bit internationally as well. And the consulting work we do is how do you put an interprofessional team together? How do you make this work? But it's also a team steps based collaboration as well. So basically we get a call saying our unit's a mess, we're not communicating, we're not working together, we can't figure out how to get this interprofessional thing going, or it's an institution that basically says, you know, our departments don't talk to each other, we're siloed just like healthcare, how do we fix this? So one of the things that we ask before we go is, so what's the barriers? What's the problems? Why are we not learning ethics together? Why are we not learning the competencies of IPEC together? And what I basically did was I took everything that they said and I dumped them into that little cute word thing. And these are the barriers. This is what they find the problem. So when you look at the word communication, you're like, well, that's a good thing, but not when it's a barrier. So the larger words are the words that came up most often. So most of the institutions that we have consulted with talk about communication being barriers, providers. Remember, providers were once students. We are teaching the future of healthcare. Hierarchy. You know, it's been siloed since 19 whatever, right? And the first IOM report was 1972 that called for interprofessional education. Team, big word in the middle, lack. Lack was everywhere. And this is kind of scary when you look at these words. You know, safety is in here, roles, these are, again, barriers, not positives. Lacking, respect, trust, you know, mutual. And you're going to see all these words in the competencies when we look at the ethics and values as well. Next slide. So we've kind of talked a little bit about the history. We talked about why it's important. You can put them all up. So there is evidence-based need for professional formation as well. So when we're trying to work together, we need to be able to work together in a way that we respect each other and that we respect what we do and what we bring to the table. Not worrying about so much who is the leader right away, but hey, you know, what do you do? What's your role? How are we going to work in a team? What is the best for the patient? So through the Josiah Macy grant, we've decided to use professionalism, as I spoke about, as the vehicle to put modules together. And there is evidence across the country for professionalism. We have to teach people how to behave together, which is a little odd because we've been communicating since the beginning of time. And the evidence base for that is healthcare educators and learners identify a need for improvement in professionalism. The people on the units, the people sitting in your seats that you're teaching, the people that you're precepting are saying, help, I don't even know how to do this. I don't know how to relate. And us as educators and clinicians, we're not giving it to them. You know, we're not really given what they need. And they're telling us that in evaluations, not just in nursing, but in everything they've ever looked at. Healthcare institutions highlight difficult issues in professionalism, assessment, and remediation. There's professional issues between residents fighting on units, between nursing faculty, between PA students, between everybody, anything you could think of. And larger institutions who are employing our students, who are now professionals, are identifying, particularly with this generation, they're having problems and they don't know what to do about it. And they call people in to make it better. There's no basis, there's nothing to teach them how to deal with these issues. They bring consultants in and they bring in personal coaches, but we need to get them, if we could, in kindergarten, because that's the first place, or the day that they're born. Let's start as early as we possibly can. 98% of medical students at 6 schools in the literature report observing unethical and unprofessional behaviors among their faculty. They're role models. This is who they're learning from, and I'm going to show you a video of that shortly. Students admit to participating in what they consider unethical behavior willingly. Feel bad about it later, some, but not everybody. And learners have reported high levels of cynicism and burnout related to their exposure to unprofessional behaviors. They go to work, they go in to do a good job, to do no harm and be the good person and take care of what they're taking care of. But the drama of the day, which is not the patient and the patient's family, burns them out. It's not their hours, it's the team they're working with. Anybody, whether it's clinical or not. So we need to start teaching interprofessional professionalism married with the IPEC competencies. So the grant that we were given by Macy's basically was to develop 12 modules. And when we talk about ethics, you're going to see that they're threaded throughout. This is not the best color to see them in. But we're going to go through a couple of them to give you some examples. Right now, they are being utilized in 13 institutions across the country in 23 different disciplines, including veterinary and dental. So today's talk is really to show you how you could use some of these videos or some of this teaching modality to teach the competency of ethics and values. Next slide, please. No, not yet. Thank you. So when you look at this core value tree, you know, when we look at values and ethics for interprofessional practice for the core competency, VE stands for values and ethics. The general overarching theme is work with individuals of other professions to maintain a climate of mutual respect and shared values. Now you think about that slide I showed you, like slide number 3 with the yellow, that talked about what is interprofessional collaborative practice. They are the same things that you're looking at in this slide. Teamwork, respect, trust. It's over and over and over again. So this is when you look at the IPEC, if you've not had the opportunity, they give you the overarching theme of the competency, and then they give you sub-competencies. Value and ethics tends to have 10. Next slide. So the first thing you have to understand, and I wish mine was caramel like the candy, but what's in your center? What is the center of what you do? You know, if you look at these things I put together, is it the right side or the left side? And you need to think about what you do every day. You know, we say we're doing patient-centered care. You know, I tell my students when they come in, and I'm a women's health nurse practitioner as well, and I say, if you haven't seen the color of her eyes before she ends your visit, you haven't seen her. Because we're always worried about documentation in the computer. You're worried about, you know, the paperwork on your desk or the questions that you have to document. You know, we're not actually looking at the patient. The other part about that, which you'll see on the other side, is we talk about patient-centered care. But who's at their center? Their family, their loved ones, their community, and anything else that you can think of. So if you think, really look inside yourself and do a 360, right? And you're thinking about what you do, what you're teaching. You make sure that you're teaching patient-centered care, family-centered care, community-centered care, because they're all one. And I really think if we look at what we're doing, we try really hard, but the time limits that we have and the students coming out have even less because of, you know, reimbursement and whatever's required of them. We're not really looking to see what's in our center. So this is a slide that shows the first 5 sub-competencies. We're going to go through 5 of them, I think is what we picked to get through, 5 or 6 of them, depending on the time that we have, to show you some of the modules and to see what you have the opportunity to present. Competency number 1 really is what we talked about, and I think is the strongest one of them all, and is placing the interest of the patient population at the center of interprofessional healthcare delivery and population programs and policies, with the goal of promoting health and health equity across the lifespan. You can read these. I'm not going to read them all to you, but what I'd like to do is just show you how, again, how we could start teaching some of these things without just standing up here and saying, okay, I'm going to lecture you about VE1 or VE2. So, Owen, you want to come up and show them?
You could pull up,
yeah.
you could pull it up.
Come on. Yeah, but he knows which. So can you pull this up to the top of the module, please? Are you able to, or do I have access to do that? Okay, so what happens with each module that I showed you of the 12? You have usually a beginning discussion of what the module's on. You have a pre-test, which matches your post-test at the end. So your student can go in and you ask them questions about what you want them to learn or what their feelings are, and they'll answer the questions. Then they have the opportunity to go through between a 20 and a 60-minute module or parts of the module. We're going to do parts because we don't have time to do what I'd love to show you today. But for the purpose of this, we're going to need to scroll down. Keep going to, I believe it's module 3, exercise 3. Yeah. You'll be able to see as it goes. This is the pre-test. Keep going. You got a while to go. Yeah. Yeah, that's okay. So they can see what's in it. So this is all the didactic, and there's videos in between. Can you really quickly go back to VE3 so we can, no, the PowerPoint, please. So what I'm going to show you now is a description of VE3, which is the third sub-competency, which is embracing the cultural diversity and individual difference that characterizes patients, populations, and the health team. So you want to pull that up and probably talk about it.
So there are lots of things there. We talked about cultural diversity. We talked about individual variation. And you saw previously that 98% of medical students from 6 medical schools that were interviewed said that they had witnessed unprofessional behavior by their faculty, which means that if I'm teaching about, birth control pills, but what I demonstrate to you in the hospital or in the office is something which is disrespectful, you're going to learn the disrespectful part just as much as you're going to learn the pharmacology of oral contraceptive. So this is not a sit there and passively, look at lectures. This is something to provoke thoughts and feelings and exercises. So you can do this all in a classroom in a synchronous way. You can do it online individually, but it really does require you to observe and to think about what's going on. So this is a video, and the attending, who this is a staged video, and the group has just come out of a patient's room. And I want you to watch the video. It's short, and to think about the ethical domain of respect for individual patient characteristics and cultural diversity. So play the video, please.
Can we see the whole video on
Jeez, come on, let's go. Next
Corny.
page.
Start from the beginning.
Oh, man. She was fat. Jeez.
Yeah, like you could roll her off the. I couldn't tell which part was.
Man.
She's just radiating.
Mike.
She needed her own scale.
Yeah, really, come on. Yeah. Mike, what are you doing? Say something.
Come on, man. You don't think it's funny?
Jeez, come on, let's go. Next
Corny.
page.
So there's your faculty member. People who make fat jokes. Sure, I've heard people make fat jokes. Obesity is a real issue in Philadelphia. More than 50% of our patients begin their pregnancy obese. We had to get new operating tables that hold patients that weigh 600 pounds. So it's an everyday activity. But if the patient were to hear her team or the patient's family or their nurses or the students talking about her obesity in a way which is laughable, that might interfere with her trust of her healthcare team. And you think maybe that the students learn not only about the medications you order, obesity, but maybe at some point, if you had the video, hopefully from decades ago, you might have them coming out of a room and the patient's a different color or a different religion or a different nationality. Cross off obesity and put something else in. So it really makes us think. So the exercise, can we scroll down?
Scroll down, please.
So before you get there, so right there is where you have to, as the learner, put your thoughts into the program. It's not passive. It requires you to think about it and then to say what you thought about this. So I know we can't get responses from the people online, but we have people in the room. So I saw some head nodding. Any thoughts if you were asked to type something? What do you think about this?
Okay, all right. So, what I saw is that the students are being taught, or the residents are being taught, the opposite of what they should be taught, because the one resident who felt uncomfortable by the conversation is being put down by the end.
So I have to tell you that when shooting this video, he couldn't actually talk. He was so mortified by even the role play that he just stood there. He was like really mortified.
Let's scroll down.
And then, you know, but what, you know, ask students to pretend to be him and how should they handle it?
So, play the video.
Next video.
In the hospital, we usually see a lot of tragic events and circumstances, and sometimes we use dark humor to get through those kind of situations. Unfortunately, that humor is of the patient. And in the case of our patient with the obesity, the humor can be pretty hurtful. And sometimes it feels like it's the right thing to want to defend the patient, but it's particularly hard to go against the grain, especially when the whole team is unified in wanting to laugh at the patient, and you know, it takes a lot of courage to even want to say something and stand up.
Let's show, can you go down a little bit and just show the way it should have gone? Yeah, go ahead.
Wow, yeah, this lady's really tough. You know, her obesity is just the crux of her problems. So what do you guys want to do next?
Maybe like get a new scale to fit her.
Where I come from, they say that she would probably show up on radar.
Yeah, that's hilarious.
Any better? No. Next video.
Yeah, wow, this lady's really tough. You know, her obesity is just the main problem causing so many other complications. So, super challenging. What do you guys want to do next?
Maybe like a new scale to fit her weight.
I know I can't tell which body part is which in there.
Well, I mean, I know you guys are pretty well-intentioned and, you know, good at heart, but, and you're just making jokes to kind of relieve some pressure here from, you know, just, but I think obesity is a real problem and she's got it, so, you know, we need to really take care of her because she needs our help. You know, I just took my board research exam last month, and you know, there were plenty of questions about obesity there. So, you know, Mario, I think it might be good if you can help teach the team about, you know, go look up some stuff about the risk factors for obesity. You know, poverty, sexual abuse, depression, and so forth. It may be at risk for, and then what, you know, obesity itself being a risk factor for so many cancers, and that showed up on my exam as well. So, you know, Matt, might be good if you can look that up as well and teach the team. Okay. Because this lady needs our help.
So you can see that using, and we've all done that, is definitely a teaching tool. You can use this online. You can have somebody write a reflection. You can have somebody have themselves in that situation as a faculty member. Any way you'd like to do it. As a clinician or administrator in the hospital floor or in an office, this also can be used for development because this happens. I mean, this is one of like many, right? Can you put the PowerPoints back up? FIT can't do it.
So the thing I think we also have to consider is that the value ethics piece is value driven. Like we all come and teaching and educating our students in an interprofessional way allows that meshing of hopefully the best of our practices. So I think that's really important for us to also consider when we do see these somewhat negative behaviors occurring.
Okay, so let's look at some examples for the fourth one. Respect the unique cultures, values, roles, responsibilities, and expertise of other health professions and the impact these factors can have on health outcomes. Same module, please. Exercise. The ghost in the thing here. It's great. Okay, scroll
Just
down.
Scroll down. Leave it 4.
Between 4 and 5.
There we go. Go on.
So they start with some questions about how you feel about teamwork. It does some didactics about teamwork. And then.
Thanks.
I have a question. This is like my 5th treatment, and last week I went to my nurse practitioner. Better.
Well, look, first of all, you've got a bad muscle injury here. The nurse practitioners, and they've done this before, they don't know what they're talking about. They just don't know. This is a bad problem. It's going to take a while. I wish they would just stick to their own business, not give me advice.
Interesting.
I see a smile.
There's a lot of people in the room online who are nodding, so you don't see it, and hopefully you're nodding at home as well. So just go a little bit down, a little bit more.
You get a comment?
Anybody have a comment? I don't know if they're
This
taking
one? No? She has you. Some? Yeah.
No, I mean, as a physical therapist, but I found it not appropriate to say in front of a patient that the other professional should mind their business. They could like contact them and see what their impression about it, professional to professional, but not in front of a patient.
Where in your curriculum are you teaching this? I mean, we talk about it, right? You know, maybe if it comes up, but do we actually talk about this? Like, do we talk about when we're talking badly about our colleagues that we may not even know what their roles are, you know? So again, as you're teaching students and teaching faculty and teaching clinicians and professionals, this is going on. Next value.
You want to do this one? You want to do?
Let's pull up the slide and see where we are.
PowerPoint.
You want to do that?
Oh, you want to do exercise 7?
Yeah, but I wanted to.
Yeah.
Can you pull up the PowerPoint? So another example, to work in cooperation with those who receive care, those who provide care, and those who contribute to or support the delivery of the prevention and health service and programs. I'm going to show you another exercise that is actually one of my favorites, because I think this happens every single day. And your students who are in clinical practice, no, go down, exercise 7, please. Thanks, Steve. Every single, keep going, day are experiencing this, and they don't come back to you and say, hey, you know, guess what I saw, because it just kind of becomes a norm to. Now you're getting a little bit of the, keep going. Going. There we go.
Thanks.
You'll recognize.
Excuse me.
Yes, ma'am.
We've been waiting for 2 hours. We were told we were going to be discharged, and I thought someone was coming right away.
I'm so
It's been
sorry.
2 hours. My mother is ready.
I'm so sorry. I have paged the provider multiple times. I will page her again.
Is there anyone else that can come?
We always have this problem with this particular provider, so I will try again, and then I'll do. I'm so sorry. I'm going to page her now.
Okay.
What? I've been trying to call you for
I've been busy.
2 hours.
I'm on the floor. I'm rounding on patients. It's really busy. What do you need?
You're not the only one that's busy. Who else is busy is a family member here waiting for 2 hours for you. That's not my job.
It is.
Repeatedly.
That's because we're always busy.
Yes, and we're all busy, and they also need to go. And
Whatever.
your
The
job
discharge
is
stuff
to go
in the
help
computer.
them.
Just go ahead and discharge them. Isn't that your job?
That's not, well, since you said that, why don't you do my job and your job,
I stay in
since
my
you can
lane.
do it better.
Your job is to do the discharge stuff. The stuff is in the computer. Do it.
You know what else is my job? Is to report you.
Next video down, please. Hit it.
Last year in school, we took a professionalism class, and we definitely learned on how to go about behaving and conducting ourselves in the workplace. And I definitely see while I'm here in person, it's quite different, and this is really how it is.
Next video. Here's the last one.
What do you need?
I have been calling you.
I've been really
for
busy.
2
I'm rounding. I'm
hours.
doing procedures. What do you need?
You have a patient. That's your job to go help them with that.
You know, it is not my job to do so. It is your job to be the nurse. It is your job to do the discharge instructions. They're in the computer. Print them out.
Why don't you do your job and my job?
It is my job to stay in my lane as a provider. You need to do your own.
Okay. To be served well. This is not helping. So let's calm down. Let's relax. You've had a busy day. I've had a busy day. So what can we do to just get this done and get the family taken care of?
Much better. Okay, so can we go back to the slides?
Hopefully, no family members saw that. I'm told.
Oh, it always happens, yes.
Oh, I know.
So, because of the time, if you can advance the slide here, one more, please. So this is the first 5, and you've seen the examples. There's many of examples, and I would love to show you 7 and 8, and I probably could do this all day long. But throughout the modules, they're matched and mapped with all of the competencies as well. A lot of these things you can do in your own institutions, and you can come up with your own scenarios and then use them in academic freedom. So like I said, you can have them log on and do it and then do a blog about it. They can do a paper, a reflection, or just a discussion in class. So, we found these very valuable throughout to help teach the values and ethics, interprofessional professionalism as well, because I think it's all tied together. Next slide. So no one size fits all. Today we just showed you, one way that you can do this other than standing in the room. But how do you do this? How do you bring people together? The best way to do it is really to put them in an interprofessional environment. Hierarchy and silos everywhere. But for us as faculty, we have to promote meaningful ideas, identify common goals, form an inclusive coalition. You've got to get everybody involved. But the problem is you can get as many people involved, but if it doesn't come from the top down, I've got news for you. You're spinning circles, and the circles are getting bigger, but you have things popping up everywhere, all over the place, and it's not really getting the momentum that you're working so hard to do. Create the common vision and walk the talk. If you're going to talk about ethics and values and interprofessionalism, you better be that person. You better be that role model walking down the hallway and dealing with your students as well. You have to really be careful. Begin with small successes. Teaching ethics and values is very difficult because it's a feelings thing. You hit lots of personal experiences and professional experiences. So, when you're talking about it, got to talk about it slowly and really be inclusive and allow for more people to talk from different backgrounds. And that's why I brought people here with me today, because you really need perspectives. Again, it's like an internal 360 all the time. Remove the obstacles and sidestep the barriers. Well, that sounds like it's easy. People are on semesters, on quarters. I know how that it's here. People schedule, people say, yes, I'll come to that meeting, and then 10 things get put in their calendar and they can't come, and it gets pushed off. The next thing you know, you're 5 years down the road. Anchor the change. My favorite quote was Gandhi, be the change you wish to see in the world. We have to anchor the change as faculty, as clinicians as well. Want to do this one?
So really the secret is that we need to begin to work together. We need to start small, and we need to literally take that knot, tie it up, and really continue to work. We've started a great collaborative in 2005, and we welcome as many people. I mean, we try hard to integrate others into it, like lull into the delivery room, not typically seen. So we're more than willing to figure out ways to help PT. And with the SIMMAN and whatnot, it can be in small groups. We can do a lot. It's just sitting here and figuring out how we can do it and how to integrate that. I think it's really the start of a beautiful relationship.
Next slide.
No matter what, semester or quarters. And these are our barriers.
Barriers to interprofessional collaboration. We've talked about this all the way through. The biggest one here is the third one from the bottom. Fear. We're afraid. I don't know what we're afraid of. People are afraid of giving up, what they feel is theirs, or, somebody might be better than me. Somebody might not do it as well as me, but really fear is the biggest that's stopping us from working in an IPE, a true IPE system.
And so our future, really, it's a collaborative approach. We need to truly become a team. We need to look at our responsibilities and how we can thread them and integrate them together. And it's practice, we get that piece, but how can we still work around the bedside, work with our families, work with the people that we're caring for in the community? And the big one, which really does lead to most of our errors and most of the issues, is the communication. And I find that's going to get worse and worse as the next generation does more things this way, and they don't do a lot of communicating with their lips. So I think it does get hard to continue to teach them and learn the skill set to communicate effectively. So all with the intent to obviously improve our outcomes for our patients and those we love, as well as reducing medical errors, now the third leading cause of death in America. So our impetus is, our collaboration themes for success, new collaborations. What can we do? Let's get together and continue this forward thrust. What are the basic foundations for that we would lie? I would say they're based on IPEC and commitment to being successful and maintaining that success. And you know that takes work. Care integration, making sure that all of our disciplines are integrated into whatever it is that we're looking at. And then incorporating IPE into all of CNHK, as well as
and wherever else you're from,
as well as the law school, as well as all of our partners. Yep.
Just and because of time, and I just want to make sure that there's no questions. Interprofessional practice environment, you can be doing drills on the floors. You can have your students, think about when they're out there thinking outside the box when they see issues in clinical of, suggesting doing and running drills on the floors. Simulation, we do that a lot here. I don't know how they do it on everybody's online or if it's done, but simulation doesn't have to be done in a simulation lab. It can be done in a classroom as well. Very low fidelity. All health providers have a part in didactic and clinical learning. We all take it separate, which is crazy. We learn the heart's the heart. It's not really going to change, the way the blood flows. I don't think it's changed since the heart was developed. But we can't seem to put our classes together, which is a really great idea. Can you imagine taking ethics in the room with 5 different disciplines?
Yes.
Yes.
Every class I teach.
That's awesome. That's my dream.
But the problem is that when students get to the graduate level, they silo.
Correct.
And so, and when I try to get it interdisciplinary, there's a lot of pushback from faculty members. But and students will tell me. So I love this whole idea because students will have conversations in class, and then they go off on clinicals, and some will come back and say, can I talk to you about something here? And we'll do like a little debriefing, like what are some of, and think about ways to problem solve. But what all the studies are showing, mentioned, is that they come in very kind of optimistic, and then they feel like there's no commitment.
Correct. Correct. Great comment. Thank you. Excellent. So as I said, we also use team steps in our group to talk about communication. And if you've not been team steps trained, you definitely should be. And you should also be putting the team steps within all of your classes, because it is really good communication tool. It is very clinical, and bringing it into the academic setting for faculty is very hard. But all of the faculty in institutions should be team steps trained as well. This is your slide. This is his favorite slide, and you got 2 minutes. You got to do it over here by the microphone.
I have to by the microphone.
Yes.
So,
he's very proud of this slide. So.
Well, so if you believe that 98,000 deaths a year, or 254,000 deaths a year, or not just the deaths, but the near misses and the errors that don't cause death are an indictment, a condemnation of siloed care, don't learn together, so they don't practice together, then you see the slide on the left, which are that in American healthcare, it's so complicated, so detail-oriented, and so distractible that we end up with care that is unreliable sometimes, very costly, sometimes unsafe. But we have evidence, not only here in the United States, but throughout the world, that if we learn together, we can practice together, and we can aspire to safe, effective, patient-centered, timely, efficient, and equitable healthcare for all. And isn't that why we got up this morning, to provide the best care we can for the people that we're here to take care of? So.
Can we entertain any questions if anybody has any questions at all? That's what I'm checking. Anybody in the room? Yes.
I think another problem is the way the system is set up for care, and not so much women's health care, because you are, you know, at least here at Hyman, it's very interdisciplinary, so it's a partnership. But you know, when I do ethics consults, it is largely communication.
Yes, it is.
And you find out even within the same profession, so the physicians involved in the case not talk to each other, and they're all talking past each other. So then they're communicating different messages to the family or the patient if the patient's able to make a decision. And then they're not talking to the nurse. And then the nurses on different shifts aren't necessarily, I mean, they're giving a report to each other, but they're not really talking. It's not, there's no team.
Right.
Until I try to organize and get everyone into one meeting, and then but that's after the problem has already happened. You know?
Correct. So we have to problem solve ahead of time, which is the hard part.
And so this is good, but I think we also have to then use this to start to try to shape the system, which is harder,
but doable.
But doable. It is.
It is.
I mean, you guys demonstrate it. Trauma does it.
Airline companies do it.
Right.
Do we have anything else? Well, thank you so much for having us, and thank you for entertaining my team. You had a 3 for today instead of just a 1. And thanks for coming. Steve, thank you for working my IT.
Teamwork.